So in the diagnosis of Hirschsprung's disease, imaging plays an important role. A plain X-ray abdomen can show us the presence of dilated bowel loops with an absence of rectal gas shadow. Because obviously a rectum is constricted or narrowed, spasmodic, so the gas doesn't enter in. And when you do a barium enema, you can demonstrate the presence of a transition zone. So a barium enema, which is done usually or ideally should be done under fluoroscopic guidance. So we introduce with the child in the lateral position, a small feeding tube is introduced per rectum with only the tip entering through the anal verge, and contrast material, which is usually barium, is instilled into the large bowel. So you find that the initial spasmodic narrow portion of the colon or rectum is delineated. Slowly it opens out to identify the transition zone, and once we reach the dilated bowel, we know that we've reached normal colon. So the demonstration of the transition zone can be done with a barium enema. Okay. Another important finding will be a reversal of the rectosigmoid ratio. Normally, the sigmoid will be lesser in size, lesser in diameter when compared to the sigmoid, compared to the rectum. When there is a reversal of this, then we know that we could be dealing with a case of Hirschsprung's disease, rectosigmoid ratio. Now, another important investigation to identify Hirschsprung's disease is a case of anorectal manometry. So you find that a transition zone, though if it is demonstrated, is likely to point towards the presence of Hirschsprung's disease. You find that large number of cases of Hirschsprung's, you may not be able to demonstrate a transition zone in a barium enema. In such cases, we can proceed with anorectal manometry. So anorectal manometry, one of the most important reflexes which are assessed with anorectal manometry, is whether there is presence of a rectoanal inhibitory reflex. If you remember, I told you earlier that if the rectum distends, you find that the internal anal sphincter relaxes and the external anal sphincter contracts to maintain voluntary control. Now, so when you have absence of the rectoanal inhibitory reflex, then we could be dealing with the Hirschsprung's disease, along with elevated resting pressures, which again could be pointing towards the presence of a Hirschsprung's. So this can be assessed with an anorectal manometry. Of course, the test, the confirmatory test, if you can say, to diagnose Hirschsprung's disease is with a biopsy. Now, biopsy, it can be a rectal biopsy, okay, or if you're planning for an operative or you have operated on a patient or opened up a patient as an emergency, you can take a seromuscular biopsy. Now, a biopsy will show us whether the ganglion cells are present at the region of suspected Hirschsprung's or whether there are hypertrophied nerve fibers. Sometimes you can use immunohistochemistry markers like calretinine to look or to stain the ganglion cells. So a biopsy will give us a definitive clue regarding the presence or absence of ganglion cells and hypertrophied nerve fibers, which in turn can help us in diagnosing Hirschsprung's disease. There are a large number of differential diagnoses for Hirschsprung's disease, or there are a number of conditions which can mimic Hirschsprung's disease, which includes a large number of visceral myopathies, and certain medical conditions like hypothyroidism, all these can mimic Hirschsprung's disease. Okay, so once we suspect a child to have Hirschsprung's disease, then usually we resort to proceed to performing a procedure called a leveling colostomy. So what is this leveling colostomy? Why can't we just call it a diversion colostomy? So a leveling colostomy is basically you open up or you operate on the child, you create an incision or make an incision in the left iliac fossa, an oblique incision. You enter into the peritoneal cavity, you enter and see the bowel which is dilated and the narrow segment below. What is ideally done, should ideally be done in a leveling colostomy is that we take a biopsy at the peritoneal reflection, which is likely to be the diseased area. A second biopsy is taken at the level of the transition zone. Then, where we are planning to site the colostomy, a biopsy has to be taken. That particular biopsy has to be sent for frozen section to see if ganglion cells are present or not. If ganglion cells are present, then that area is brought out as a colostomy. So basically, we do a frozen section, see where the normal bowel is, and then bring it out as a colostomy. So that is what is meant by a leveling colostomy. So a leveling colostomy is a precise colostomy, or a procedure wherein there is a precise demonstration of ganglion cells in the large bowel and ensures that the area which is at the bowel which is brought out as an ostomy has ganglion cells in it. So this is helpful because it helps us, it prevents wasting of bowel while performing the colostomy and ensures that the bowel that we bring out as a colostomy definitely has ganglion cells because you have demonstrated it by frozen section. So what happens if you don't have frozen section? If you don't have frozen section to demonstrate the presence of ganglion cells in the portion of the bowel you are going to bring out as an ostomy, then we will have to resort to an arbitrary method of bringing out the bowel as a colostomy. So if you don't have frozen sections, then what is generally done is that we identify the transition zone, go 4 finger breadths above it in the dilated bowel and bring that out as an ostomy. So that is done if you are not able to, if you don't have frozen section. So when you have frozen section, we are able to correctly level the site at which the colostomy can be done. Then that particular colostomy is called as a leveling colostomy. So once you do a colostomy, it will facilitate normal drainage of stools outside. The child will slowly start gaining weight. The nutritional status of the child will improve. And once all that happens, you go in for a definitive procedure.